Hello, everyone. Thank you for joining Career Search today for this very important webinar on how to improve awareness of LGBTQ plus community members. I'm your host for the webinar, Paula. At Career Search, we're focused on providing emergency and healthcare professionals with the training they need to best protect and care for those in their communities. And we're grateful for this opportunity to connect with you. It's my pleasure to introduce you to our presenter for this webinar, Quo Downing-Rees. Quo is a 20-year EMS veteran with experience in LA County private ambulance, fire, and hospital ED, as well as upstate New York EMS. She attended paramedic school at UCLA Daniel Friedman and holds an EMS management degree from George Washington University. Quo is also an EMS and medical instructor at Career Search, NYS Certified Instructor Coordinator, NAEMT Instructor, ASHI Instructor, and AHA Regional Training Center Faculty and Coordinator. She is a nationally registered paramedic, flight paramedic certified, critical care paramedic, and specialty care transfer paramedic. We have included the slides from today's webinar as a handout that you can download, and we will be taking questions throughout, so be sure to share those in the webinar chat. They will be answered either at the end of the slide or at the end of the presentation. So now, Quo, I will let you take it from here.
Hi guys, my name is Quo, and welcome to our webinar. I appreciate all of you joining us today. So our goal here is that we're going to try to create a safe and welcoming environment for everyone here, and that would include obviously people of the LGBTQ plus community. So part of our goal here is we're going to openly talk about and display some LGBTQ plus topics. We're going to briefly talk about terminology and definitions, and we're going to learn how we can be kind of open and fair, create a safe place for these folks in our policies and procedure manuals and how we deal with them, whether it be our patients or our coworkers. Be aware of some of the issues that they deal with, because there are quite a few, and to recognize, is there any kind of specific health concerns or things that we should know about with these populations? So let's get started. So these are just some of the terms that we use in the LGBTQ plus community. They are pertinent to the medical service provider. Some are pertinent more to the community. Remember that with this, it's always going to be dependent on how the patient views themselves. So there are lots of different terminology terms here that you can see, but like say, for instance, lesbian, pansexual, queer, transgender, any of those are all going to be things that are going to be based off of how the patient themselves or your coworker identifies themselves. So it's not up to us to say, oh, you're a lesbian, or oh, you're transgender. It will be up to them to decide how they would like to identify. So, and if you want to learn more about any of the terms that are in that previous slide, we do have a course at Career Cert, as it is called LGBTQ plus awareness for medical providers, and then it will go over each and every one of those terms. Under no circumstance should you ever use any term or phrase that could be insensitive or offensive towards any patient. Your responsibility is to give your patient the best care and compassion you can, and using insensitive or offensive language can severely damage the patient-provider relationship. Also, don't make assumptions about a patient due solely on how they look, sound, act, etc. The LGBTQ plus community is one of diversity. We as medical providers should be prepared for a patient with a gender expression, clothing, hairstyles, pronoun uses that may differ from what we assume. For example, a transgender man early in their transition, meaning that they're taking steps to reflect their gender identity through physical expression, they may still have feminine features such as breasts or feminine fat distribution. One of the best things you can do is listen to your patient and be respectful of how they choose to define themselves. So for instance, never use any of the offensive terms and phrases that you see listed up here. We don't want to say things like, when did you decide to become a man or a woman, or you don't look like a lesbian. Those things are really hurtful, and they really do cause mistrust within that population, whether it be with a coworker or with your patient. Um, In most societies, a common perception of gender is that of binary, or two separate and distinct genders that correlate to the biological sex or the sex at birth of an individual. According to this conception of gender, gender identity, the internal understanding of one's gender, and the gender expression, which is the external signaling of their gender identity, are linked with no overlap between genders. An alternative view is that gender is on a spectrum instead of a specific binary. Gender as a spectrum offers more nuances to one's gender identity and expression, and can encompass non binary or non specific masculine or feminine gender identities. The Thai view of sex and gender identity could be described as a spectrum. The Thai culture recognizes 18 gender identities, combining biological sex, sexuality, and identity in their descriptions. And that's not just one example. A Native American also have different views. Many Asian cultures have different views. So that's something that is specific. Gender binary kind of is a little bit more, I think, Western based thought process. So, being open to that spectrum is very important for us. And remember that it is sometimes based in their culture. So it's important to note that just because a person is transgender does not mean that they are necessarily heterosexual or attracted to members of the opposite gender. A person's sexuality or sexual orientation is always unique. For example, a transgender man could be attracted to women, men, or both. Just as in cisgender individuals, meaning people that are born and they identify with the gender that they appear as, sexually exist on a spectrum and is unique for everyone. Alfred Kinsley, heterosexuality, homosexuality rating scale, which you see, pioneered this idea in 1948, with the final iteration of this scale representing 7 categories, ranging from exclusively homosexuality to exclusively heterosexuality. People can be attracted to men, women, both, or any gender identity in between. It's not our place to judge or make assumptions about your patient for their sexual orientation or gender. So you can see the different overlap that you can have with all of the different colors there. Some people may say that they're bisexual, some may say pansexual, some say that they're heterosexual, some say homosexual. So there's all kinds of different versions, and you see that I didn't even name all of the different things that are up there, but just so that you guys kind of get an idea. And again, I always just I ask the patient, how do they identify? So let's talk quickly about some of the history. So the Stonewall riots in 1969. In the early morning hours of June 28th, 1969, a 6-day protest erupted after the New York Police Department raided the Stonewall Inn, which was a Greenwich Village bar that catered to the LGBTQ plus community. At the time, there were many laws in place that made it illegal for same sex people to publicly show affection, and even gender appropriate clothing laws. And police raids on businesses friendly to the LGBTQ plus community were commonplace. As a large crowd formed to watch the raid, a lesbian was struck in the head by a baton as police attempted to put her in a patrol wagon. The crowd began throwing objects at the police in response, and a riot broke out and continued intermittently for the next several days. Many believe that the riots marked the beginning of the gay rights movement in the US and brought out and proud members of the LGBT plus LGBTQ plus community into the public eye. 1 year after the riots, the first gay pride marches took place in New York, Los Angeles, and San Francisco. In 2016, President Barack Obama made the Stonewall Inn and the surrounding neighborhood a national monument in recognition of its contribution to the gay rights movement. Back in 1994, President Bill Clinton's administration instituted Don't Ask, Don't Tell, a directive that prohibited military personnel from discriminating against and harassing closeted LGBTQ plus service members, while simultaneously barring openly gay, lesbian, or bisexual persons from service. This directive was challenged multiple times in court, resulting in settlements in favor of LGBTQ plus service members that were actively discriminated against. Over the course of the 1990s, opinion of the LGBTQ plus community shifted positively, leading to greater acceptance of openly gay individuals. In 2010, the directive was repealed, allowing openly LGBTQ plus persons to join the military. One of the most recent events in the history of the LGBTQ plus community in the United States is the U.S. Supreme Court decision in Obergefell and Hodges. The ruling required all states to issue marriage licenses to same-sex couples and to recognize lawful same-sex marriages in all states, which greatly expands the national understanding of discrimination and inequality. Despite this ruling, the LGBTQ plus community still faces prejudices in a myriad of ways. For instance, on February 18th, 2007, Janice Langban and her partner of 18 years, Lisa Pond, were preparing to go on a cruise with 3 of their children. Before departing the Miami port, Lisa had a medical emergency and was taken by ambulance to Jackson Memorial Hospital Ryder Trauma Center, where she was diagnosed with a brain aneurysm. Janice and the children were refused access to Lisa for more than 8 hours, despite presenting a valid power of attorney. Janice was allowed to be at the bedside for 5 minutes when a priest arrived to administer the last rites. The children and Janice were not allowed unrestricted access to Lisa, who had been moved to the neuro ICU until the arrival of Lisa's sister. Lisa died the next morning without her children or partner of 18 years by her side. 4 months after Lisa's death, Janice spoke out publicly about the treatment of her family, which garnered the attention of the Obama administration. In April of 2010, President Obama issued a memo to the Department of Health and Human Services in response. In this memo, he outlined 3 steps for the HHS to take regarding hospital visitation. With the implementation of these steps, the compassionate care and equal treatment necessary for any hospital stay was formally extended to same-sex couples, ensuring hospitals cannot deny visitation based on sexual orientation and gender identity. These regulations were finalized in 2010 as a condition for participating in Medicare and Medicaid and apply to all hospitals nationwide. So please keep that in mind when you are transporting patients and they tell you that they have a same-sex partner or a partner that may not identify in the traditional, let's say, way, that they are still a spouse or that they are still a family member, and to recognize any documentation that may be presented to you legally, such as a valid power of attorney or a healthcare proxy. Many of the risk factors to the LGBTQ plus population are directly related to unique social issues that affect this community, including coming out or staying closeted, disproportionate rates of rape and intimate partner violence, suicide, and hate crimes. Coming out is also known as a process of acknowledging yourself and others, and in part of the social transition that occurs in the LGBTQ plus community. Coming out can be done in a number of ways, from opening up about themselves to a small group of friends or family, to a public announcement or social media post. It is important to note that if the person has come out to a particular individual, this does not mean that they have or even will come out to everyone in their family or social group. That is really important to know about your patient, and make sure that if you feel like you needed to talk to any of the other family members for that patient or loved ones, that you ask your patient beforehand if they are okay sharing that status with their family members. There may be reasons for their own safety, for instance, that they don't disclose that information, and you don't want to be the one who kind of um, for lack of better word, out that patient to those people. It could cause a safety issue, or an issue for them to lose support from that family member or loved one. So just make sure that you're aware of how open they are with the people that are in their lives. The decision to come out has a profound impact on the individual. Coming out may change social interactions and networks, often negatively, and the decision is frequently associated with fear of rejection. Consequently, many members of the LGBTQ plus community choose to remain closeted. When a person is closeted, or known as in the closet, this means that they choose not to disclose their sexual orientation, gender identity, etc., publicly to others around them. Their decision for remaining closeted could be due to any number of factors, such as potential rejection by family, religious beliefs, or employment repercussions. The reasons LGBTQ plus people have for remaining closeted may also dissuade them from seeking out medical care when they need it. Some have felt that when they come out, or when they tell their medical provider, that they get treated differently. And so they don't want their provider to know, because they feel like they may not get the best care. So the questions you are asked are vital for obtaining a thorough and accurate patient history and establishing a rapport with the patient and their family. The ability to ask the best and most appropriate questions will only help you be a better medical provider. The more we know who a patient is, the better we will understand the patient and their needs. So, is it appropriate to ask if a patient has come out? Yes. It shows that you want to respect the privacy of the patient. If they haven't come out, you should respect that information. Unless it directly impacts their care, that information does not necessarily need to be shared. If it does impact their care, choose to limit the people with whom you share the information. Is it appropriate to ask the patient if it is okay to share with other caregivers? It is. Be diligent about protecting the patient's privacy with regards to family members. Oops. LGBTQ plus coworkers. While this course focuses on the needs of and interactions with members of the LGBTQ plus community who will be your patient, it's important to remember that some of your coworkers will be members of this community as well. They should be treated with the same dignity and respect as anyone else. For example, if your partner tells you in confidence that they're gay, bisexual, transgender, etc., respect their privacy. Just as you should not out a patient, do not disclose this of your own violation. Don't assume that since they've told you, they've told others. Let them come out to others whenever and however they choose. As a provider, you should be aware that any patient could be a victim of intimate partner violence, also known as IPV. According to Tanya Poteet, she is a PhD. Healthcare providers do not ask lesbians about IPV as often as they do heterosexual women. So you should be asked this question as a female, regardless of who your sexual partner is. And in fact, there is quite a high incidence of it in the LGBTQ plus community. The statistics demonstrate that the healthcare provider should be asking all patients about IPV and be prepared to provide them with the resources and help they may need. So please keep that in mind. Ask all patients, men and women. The rates of suicide attempts are drastically higher in the LGBTQ plus population when compared to the heterosexual population. The risk of attempted suicide increases by more than 8 times in individuals who experience rejection by their family when compared to individuals with no family rejection. Physical or verbal harassment of LGBTQ plus people increase the risk of self-harming behavior 2.5 times. The social pressures on the LGBTQ plus community also contribute to substance misuse. For example, lesbian, gay, and bisexual adults are 2.5 times more likely to smoke cigarettes compared to straight adults. And as much as 25% of the LGBTQ plus community has moderate alcohol dependency. When you encounter a teenager who has attempted suicide, you may consider inquiring about their sexuality issues in the course of treatment. The patient may be more forthcoming if you are welcoming and non-judgmental practitioner and you offer a safe environment in which a candid discussion can occur. Be prepared to offer referrals to a social worker or psychological psychiatric assistance to these patients. There are also a variety of nonprofit organizations that focus on assistance for the LGBTQ plus community. For instance, the Trevor Project. The Trevor Project can be an important resource for these patients. The Trevor Project is a free suicide prevention organization for LGBTQ plus youth under 25. Counselors are available 24 hours a day by phone, text, or website chat to help the LGBTQ plus youth in crisis. And there is a link that we can share with you to give you more information on that. Support lines such as the Trevor Project saves lives, and you can make a huge difference by providing a patient with welcoming resources. As healthcare providers, we should view this type of assistance as important as providing oxygen to someone who can't breathe. The Shepard-Byrd Act of 2009. So in 1998, Matthew Shepard, a 21-year-old gay college student, was brutally beaten, pistol whipped, and tied to a wooden fence in freezing condition by two men in Laramie, Wyoming. He died in the hospital 6 days after the attack. His murderers justified their actions by claiming that Shepard made a sexual advance towards them, known as the gay panic defense. In 2009, the Matthew Shepard and James Byrd Jr. Hate Crimes Prevention Act was signed into law. It expanded the 1969 federal hate crimes law to include crimes motivated by a victim's actual or perceived gender, sexual orientation, or gender identity. Afterward, the FBI became authorized to investigate crimes committed against those based on biases of actual or perceived sexual orientation, gender identity, disability, or gender. Previously, the FBI was limited to hate crimes, investigations that were based on a bias against the victim's race, color, religion, or national origin. Though hate crimes against the LGBTQ plus community have been federally defined, not all states recognize the same guidelines for what constitutes a hate crime. So the gay trans panic defense. The gay panic defense is essentially a justification for violence against a person, against a member of the LGBTQ plus community. While it is illegal in 8 states, with 8 others considering a ban on the gay panic defense, it is still used across the country as a justification for assault and murder. If your patient has been a victim of a violent crime, remember that there is a possibility that they were attacked solely due to their gender expression or sexuality. As providers, we should be sensitive to this. Approach this topic delicately and with compassion. Transgender. Let's talk about that a little bit. Transgender is the gender identity or expression that differs from their biological sex. Those people require the same preventative medication that cisgender people that gender identify or express matching their biological sex people require. However, there are some special concerns regarding the trans populations when they have begun their transition, which is the process of aligning their physical attributes to their gender identity. Finding appropriate health services, including doctors and nurses who are open to serving transgender patients, can be a challenge. The National Transgender Discrimination Survey, conducted by the National Center for Transgender Equality, found that almost 20% of respondents has been refused medical care outright due to bias. This deficiency is available resources may cause transgender individuals to resort to black market steroids or hormones or back alley surgical procedures to transition. The lack of safety and resulting complications associated with these choices put the patient's health and well being in jeopardy. One of the best things you can do as a medical provider is to listen to your patient. Be sensitive to their needs. Ask which pronouns they use and then use those pronouns. If you make a mistake, apologize and move on. Mistakes happen and you should not make a big deal out of it. Also, just as someone may have had an unpleasant interaction with a specific individual medical provider in the past, they may also have had unpleasant interactions with entire medical institutions. Always ask your patient their preferred medical facility whenever hospital transfer or initial EMS transport is necessary. Um, and you may hear a patient say something like they dead made me there, meaning like that they'll use the patient's legal name and not the name that they choose for themselves because it hasn't been legally changed yet. And they really don't appreciate that, or they don't appreciate how they are treated, or the pronouns are always, obviously use the pronouns that they do not identify with, and those things make it very uncomfortable for the patient. So you may hear that term like they dead name me there, or they don't use my pronouns, or they don't use my appropriate gender identification. So transgender women, some things that we need to consider. So recall from the introduction that a transgender woman has transitioned or is transitioning from male to female, also known as MTF. Trans women will often take supplements of estrogen, progesterone, and testosterone blockers during to increase the femininity of their appearance. So let's talk about the hormones. Estrogen increases the risk of blood clots, swelling, high blood pressure, and high blood sugar levels. Progesterone helps to increase breast size, redistribution of body fat, and minimize facial hair without any major adverse reactions or unwanted effects. And testosterone blockers, spironolactone is a medication that blocks testosterone. This drug can be dangerous for people with kidney problems, and it also interacts with some blood pressure medications. Finasteride and duosteride are medications that prevent the production dihydrotestosterone, which is a specific form of testosterone that impacts the skin, hair, and prostate. These medications are weaker testosterone blockers than spironolactone, but have fewer side effects. So keep those in mind for women, um, trans women that may be on those. For transgender men, um, remember recalling that transgender men are transitioning from female to male, also known as FTM. Trans men will often also take supplements of testosterone to increase the masculinity of their appearance. So, testosterone, either injectable or transdermal, increases the risk of high blood pressure, diabetes, heart disease, and high cholesterol. It can thicken blood, which increases the risk for stroke and heart attack. It should not be administered in pill form due to the increased risk of liver toxicity. As part of the process of transition or shaping one's outward appearance to more closely match their gender identity, a person may wish to have these surgeries performed. Many of these treatments must be coupled with mental health evaluations and approvals prior to insurance approval. These surgeries are often not covered by insurance and are quite costly out of pocket. Also, prior to removal of reproductive organs, one may opt to preserve their sperm or eggs for possible future use in order to have a biological child. Depending on where a person is in their transition, a person may or may not have had these surgeries. And, excuse me, and it is still possible to become uh, pregnant, or uh, they may never undergo the surgeries at all. So keep that in mind, that just because a person is transgender does not mean that that they will have the surgeries. So a male to female may look female, but they're obviously not going to have their period, versus a female to male, they may look male, but they could still get pregnant, for instance, and they may still have their period. Usually not because of the testosterone that they're taking, but it is possible, especially if they're early on in their transition. Um, Also remember that addressing whether a transgender person has a specific surgery is not relevant unless they're experiencing complications from a recent surgery. For example, it is inappropriate to ask, have you had top surgery? However, it is always appropriate to ask about surgeries in general. So be thorough when obtaining your patient's history. I will ask a female to male um, person who's transitioning sometimes about surgeries involving, have they had a hysterectomy, only because of cancer risks and other abdominal risks. It may be pertinent to ask transgender men, female to male, if they still have their ovaries or uterus, as it's possible to become pregnant, which we discussed. Remember that medication in medicine, if a patient is a female of childbearing age, it's an ectopic pregnancy until proven otherwise. This is an issue that must be approached with care and concern for the well-being of the patient rather than judgment. So you have to be very careful with discussing that and how you present yourself trying to discuss that. If your patient is hesitant to divulge any pertinent information regarding surgeries, remind them that anything they say is in complete confidence. Help them understand that you're just trying to treat them and you're not there to judge them for anything in their body. Black market treatments also carry considerable risk. Fostering a safe and welcoming environment for your patient will encourage them to open up to you about potentially dangerous treatments that they have pursued. As with any surgery, assure them that everything is said in complete confidence and you will only help you provide better care. So some things to consider. Gay men are more likely to suffer from depression than the general population. Adolescents and young adults may have a higher risk of suicidal ideation. Be prepared to refer a patient to a social worker, a psychologist, or a psychiatrist. Drugs and alcohol use is higher among gay and bisexual men. Also, they're more likely to use amyl nitrate, or what's known as poppers, ecstasy, and amphetamines. Always encourage your patient to be open and honest with you about their substance use. Tobacco use. Gay men are much more likely to use tobacco products. Watch for lung disease and cancer, heart disease, high blood pressure, etc. Fitness. Gay men are more likely to suffer from eating disorders and can also suffer from obesity. The use of anabolic steroids and other supplements can be dangerous if used excessively. Encourage your patient to be honest about their sexual health, especially if it's pertinent to the care you deliver. So, what kind of sexual transmitted diseases may they have, or, are they using protection? Do they have more than one partner? Lesbian and bisexual women may suffer chronic stress from discrimination. Those who are not out, as we say, are more likely to suffer from this, potentially leading to depression and anxiety. Be prepared to refer this patient to a social worker, a psychologist, or a psychiatrist. Drug, alcohol, and tobacco use is higher among lesbian and bisexual women than heterosexual women. Always encourage your patient to be open and honest with you about their substance use and how much they use. As far as heart health, smoking and obesity increase risk for heart disease among lesbian and bisexual women. So watch for high blood pressure, cholesterol problems, and diabetes. Breast cancer. Lesbians are more likely to have risk factors for breast cancer and less likely to be screened for it. Intimate partner violence, IPV, lesbian and bisexual women are not asked about IPV as often as heterosexual women. As a provider, you have a responsibility to ask every patient if they feel safe at home. That does also include your men. Gynecological cancer, lesbian and bisexual women are at a higher risk for certain cancers due to higher rates of obesity, hypertension, and etc. So keep that in mind. And again, always encourage your patient to be honest about their sexual health, especially if it is pertinent to the care that you are providing. Offering yourself as a resource for the LGBTQ plus community by advertising non-discrimination policies that include sexual orientation and gender identity will help in creating a welcoming environment. Consider reaching out to other organizations such as Planned Parenthood to network and have joint sessions regarding medical issues facing the LGBTQ plus community. Also consider reaching out to community organizations and nonprofits to discuss needs of the LGBTQ plus community. On registration or insurance paperwork, have a block for the patient's legal name and a block for their chosen name. Openly discussing LGBTQ plus materials will also help create a welcoming environment. Ask patients to participate in patient satisfaction surveys and ask for feedback regarding how you can make their healthcare experience more comfortable and pleasant. I find that is very important. They really find it very welcoming if you ask them what their chosen name is and then use it. And this actually goes with everybody, not just people of the LGBTQ plus community. Approaching all patients with an open mind and willingness to serve them is crucial to positive patient care outcomes, regardless of a patient's sexuality, gender identity, or gender expression. You should always provide the best possible patient care. Always consider the challenges LGBTQ plus patients face both physically and psychologically when you're performing assessments, and be cognizant of the social issues that the LGBTQ plus community faces, such as hate crimes and IPV, and be cognizant of any inflammatory language that could be offensive. Remember that there are different factors to look for in different subsets of the LGBTQ plus population. Recognize the value of presenting a safe and welcoming environment to the LGBTQ plus patient, and create a safe and welcoming environment is important for any patient in your care and can be especially vital in building rapport and trust with your LGBTQ plus patient. Thank you very much, guys. Do any of you have any questions? Give
Well,
you
I'm
guys a
not seeing any questions
chance.
in the
No
chat.
question?
I don't think so.
I
If you
don't
have some
see
questions, you can
any.
share that in the chat and we can read them. We'll be able to answer those. In the meantime, just wanted to say, if you would like to earn free CAPCI accredited CE hours for attending this webinar, you need to complete the assessment we will distribute to you, which will be sent to your email in the next 48 hours. So once you complete the assessment, we will automatically report your CE hours to CAPCI. So be on the lookout for that, and emails if you have any questions. You can visit us at careersure.com for more webinar information and free resources to help prepare you to improve patient outcomes. I don't think we have any questions closed, so thank you so
Okay.
much. Oh, I think we have one. Sorry,
Oh,
let me see.
okay.
I'm going to copy and paste that so you can see it, because I'm not sure if you can see the questions.
I don't see the question currently. Okay.
Yes, this is the
When
second
unsure
one.
of a patient's biological sex, what is the best way to ask the patient's physical biological sex without offending? So normally what I have found is I'll ask them very politely, um, you know, I'm not quite sure what biological sex you are, or what you identify with, and so if you think that you can, if they tell you what they are, you can ask them, politely, is that your biological sex? um, and generally they'll tell you yes or no. If you've been fairly open with them and created a safe environment, they're usually very open. I find that if you use the pronouns that they prefer, if you, act like you're open, you explain the reasons why you're asking those questions. Like for instance, when I have to ask a female to male transition, patient if they have had any surgeries, including like a hysterectomy, and I say it's pertinent to your medical care, usually then they are a little bit more likely to answer me. So, for instance, if their main complaint was about abdominal pain, I do have to tell them, there's always a risk of, things like cervical cancer or, things that are, female or reproductively related. So it's important for me to know, is your biological sex female or male? So that may be one way to say it. A lot of it is tone of voice. If I come at you and go, what's your biological sex? That's not very opening. Versus if I say, so I'm not quite sure what your biological sex is, but I just kind of want to make sure that I'm correct. And you can make an assumption. I guess in that case, you could say, it appears to me that you may be biologically female. Am I correct? And they can say yes or no. And if they say, no, I'm male. Oh, I'm very sorry. I hope I didn't offend you, and usually they'll say yes or no, whatever. But you can hear the tone of my voice is much more welcoming, much less judging kind of sounding. I think that will go a long way for you to do that in a positive way. Are there any other questions?
Thank you, Co. I think that's the only question that we had. So again, I want to
All
thank
right.
you and thank you
Thank
everyone
you.
for connecting with us today. So thank you for your sacrifice to make our community safer places, and stay safe and take care. Thank you, everyone.
Thank you.